of quarantine, which is specified in the law, quality assurance, reconciliation, how many vials are there, how many are broken, how many needs to be returned back, and all of those issues. These are all necessary for the safe distribution of the vaccine. These processes will take a minimum of 10 days and a maximum of 14 days to complete, upon which we will then be ready to distribute the vaccines to all the provinces. The National Vaccination Campaign is a government-led initiative necessarily supported by other sectors, such as the civil society, the unions, the private sector. The framework that will be presented tonight has received support from these and various other players to ensure that we achieve our goal of population immunity or herd immunity by the time we get towards the end of the year. As a government-led initiative, Treasury has put its full weight and its support behind the program, and I must take this opportunity to thank the Minister of Finance and Treasury officials, in particular the Chief Procurement Officer, for the close working relationship that has defined the processes of procuring the vaccines. They've ensured that that there are no undue delays. They've granted us all the necessary deviations that we have requested and committed to financing additional orders. Just this afternoon, Treasury met in a three-a-side meeting with the Department of Health and Business. This type of multi-sectoral collaboration has borne the fruit we need to fuel our ambitious program. As we announced in the statement on the 22nd of January 2021, the Department of Health has made direct application to SAPRA for Section 21 authorization to supply the SII and AstraZeneca vaccine. This approval has been granted, and we do have the CEO of SAPRA, Dr. Boitumelo Simete Mokokoteka, here to take us through the authorization and how it will translate on the ground, as well as the processes envisaged for authorization of the candidates that will be used in the country. Another regulatory hurdle we had to manage was the GMO regulations under the Department of Agriculture that need to be adhered to for the importation of organic goods derived from genetic modification. It gives us pleasure to confirm that the Minister of Agriculture, Land Reform and Rural Development has signed regulations to waive the 30-day consultation period so that the agency of the vaccine rollout can be accommodated. This is in line with the requirements of agency under the disaster management situation. We're therefore pleased that from a regulatory standpoint, we are cleared to move ahead with the rollout of the vaccine and the mass inoculation campaign. Today, I'm joined by senior officials from the Department of Health, whom we will invite shortly to take us through the details of the phase 1 inoculation. I'm also grateful to be joined by the representatives from the private sector, professional bodies, community pharmacies, business and healthcare funders, as this is a culmination of many months of engagements, hard work and cooperation across sectors to ensure that we have a coordinated and well-capacitated vaccination program. I thank all these esteemed colleagues for joining us tonight, and we look forward to their critical contributions. To conclude, therefore, I wish to acknowledge that as a country, for us to expect our first consignment of vaccines less than a year after the first case of COVID-19 was recorded is a massive achievement of unprecedented proportions. And this is thanks to the coordinated and focused efforts of the international scientific community, researchers, clinicians, and experts, as well as the cooperation of the various departments of government. However, today I want to pay special tribute to those fearless compatriots who volunteered to participate in the trials, doing so without knowing whether they are getting the vaccine or placebo. Let us not forget these heroes who defied all anxieties and chose to be of service for the greater cause. It's only through human trials that we can truly establish the safety and efficacy of the vaccine. They were those humans. We thank them for the noble contribution which has brought us to where we are today. Without much further ado, let us then get into the business of this webinar. I'll therefore revert back to Dr. Manzi to introduce the first speaker, for today. And at the end of it, there will be an opportunity for us to answer some of the questions that you might wish to pose. Thank you very much. Please, Dr. Manzi, if you can proceed from there. Thank you.
Well, thank you very much, Minister. I must tell you, Minister, that the excitement is absolutely fever pitch. As you were talking, I was receiving phone calls from journalists saying, goodness me, all this breaking news. Thank you very much, Minister. Now, what we're going to do is we're going to take the public through the details of the phase 1 inoculation plan. Just to take the public just through the program itself for this evening, we have had our opening remarks from the Honourable Minister. We will now have Professor Barry Shoop, who's going to talk about how vaccines were made so that we all understand exactly what goes into the technology of making vaccines. We will then have Dr. Anban Pillay from the Department of Health, the Deputy Director General, take us through the different vaccines, their efficacy, how they get used, and their safety profiles as well. We will then get our information systems guru, Ms. Melanie Wilmerans, to then take us through the electronic vaccination system. This is the system which we said would be the system where we capture all those who are going to be inoculated and ensure that we can keep track of their inoculation and issue the inoculation certificates. Then Dr. Aquina Tulari from the Department of Health as well will take us through the service delivery model and funding. And we'll talk a little bit more about what will go into that particular discussion when we get to her segment. We will then have Professor Kollega Mnisana, who will give us a talk on myths and misinformation as an expert in the fields of virology and epidemiology. We will then have Dr. Boitumelo Semete Mukukotlela, who will talk to us from SAPRA, as the CEO of SAPRA, on the Section 21 approvals, the details thereof, safety and pharmacovigilance that SAPRA undertakes with the vaccines. Thereafter, we will have a question and answer session, and we have tried to set aside quite enough time so that we are able to exhaust all the questions. And we will then have the Deputy Minister and the Minister closing for us by first addressing our people in vernacular, and then the Deputy Minister will then close the session for us. And so, without much further ado, I would like to invite Chair of the Ministerial Advisory Committee on Vaccines, Professor Barry Shoop, to give us a presentation on how vaccines are developed. Professor Shoop, I see you there. Thank you very much. Over to you.
Thank you very much, Dr. Manzi, for that introduction. Honourable Minister, Honourable Deputy Minister, the Director General, all protocols observed. Thank you very much and good evening to everybody. My job, as Dr. Manzi said, is to really give a very brief overview of how these vaccines are made. So I'm going to spring right into my slide presentation. I just need to have permission to open the slides. At the moment, I'm disabled. Otherwise, I wonder if the host can just give me... Oh,
okay,
right.
Professor Shoop, my apologies. It looks like you will be able to share your screen now. Thank you.
Doesn't seem to want to. Disabled, it's disabled. It's not allowing me to share.
Professor, we'll just attend to the technical problem at the moment. Thank you and apologies.
I hope it's not infected by a virus. Sure, I'll speak
Professor
without...
Shu, we have made you a co-host. If you're not able to share the presentation, I think if Professor can just go ahead and just present without the presentations.
Okay.
If that
I'll speak without. No, that's fine. All right. Our classical way in which viral vaccines were made. Sorry.
Can you see if you can try again? We have made Professor the host now. Let's just try again.
No, it says disabled. The host has disabled my participant to screen sharing.
Okay. No, please go ahead, Prof.
Okay.
Please go ahead without the presentations.
Okay. You'll have to just imagine what I'm saying then, graphically. Okay, the classical way in which vaccines, well, particularly viral vaccines, were made were really threefold. One either took the virus and attenuated, in other words, grew it in an unnatural environment and thereby changed the ability of the virus to cause disease. The virus was still able to infect the host and thereby stimulate the immunity. And those we call live attenuated viral vaccines. There are a number of examples: measles, mumps, rubella, oral polio vaccine, yellow fever vaccine, and so on. The second way is to take the virus and inactivate or kill it. And we do it either by heating or chemical inactivation. And again, the inactivated polio vaccine, the hepatitis vaccine, these are examples of inactivated whole virus vaccine. And then the third way is to actually extract the critical proteins which are needed to stimulate the immune system and use that as the vaccine. So these are the three classical ways in which are used to make vaccine. And there are numerous examples of all three of these. Now what's happened with the coronavirus, or the cause of COVID, is that there are now additional modern ways of making vaccines, ways which we had not used before. Now, the critical part of the coronavirus is those spikes, those outer proteins on the outside of the virus. These spikes are what attaches the virus onto the receptor site in the cells that the virus is going to infect and thereby establish infection in the host. So it's the spike protein, and particularly the part of the spike protein which attaches the receptor site. We call that the receptor binding domain. And the idea of a vaccine is to stimulate immunity in the host so that the host will make antibodies as well as immunocompetent cells to stop that spike protein, the receptor binding protein of the spike protein attaching to receptor sites. So there are various ways in which, in fact, various imaginative ways in which these vaccines are now being developed. Up to now, they're close on 300. There are about 292 prototype vaccines which are being investigated in different kinds of ways, using the classical ways, but also using novel ways to make coronavirus vaccines. Now, of these, there are really 6 vaccines which are in common use today, from those 290 which are still being developed. There's the AstraZeneca vaccine, there's the Johnson & Johnson vaccine, there's the Moderna vaccine, there's the Pfizer vaccine, there's the Chinese vaccine, the Sinopharm from China, and the Sputnik vaccine from Russia. Now, 2 of these vaccines use what we call messenger RNA. Remember, the virus itself, the genetic code of the virus, is actually an RNA strand, a single RNA strand. So how the mRNA vaccine works is that the particular part of that strand is snipped out. It's that part which will code for the spike protein, and in particular, the receptor binding domain. That's snipped out. Now, messenger RNA is a very, very fragile molecule. It can't be used as such. It has to be protected some way. So it's put into a nanoparticle, a tiny, tiny lipid particle, a fatty particle, to encase it and protect it. Also, that's why the Pfizer vaccine is so sensitive to heat. It's got to be stored at -70 because the mRNA is very, very fragile. The lipid particle then gets injected into the arm. It's taken up by the muscle cells at the injection site, and the RNA then gets into the muscle cells. Once it's in the muscle cells, it can then translate the spike protein and the receptor binding domain of the spike protein, and thereby stimulate the immune system. So that's how the messenger RNA vaccine will work. That RNA, remember, is a very fragile molecule. It doesn't last long in the muscle cell. It's quite rapidly degraded after it's done its work of producing that protein. So that's the one group of vaccines, the Pfizer vaccine and the Moderna vaccine. The AstraZeneca vaccine, the Johnson & Johnson vaccine, and the Russian Sputnik vaccine, they are a little bit similar, but quite different. The way they work is that one takes that relevant piece of RNA, and that's spliced into a carrier virus. The virus which is used is called adenovirus. It's a virus which does infect human beings, but is usually a trivial cause of trivial illness. But the AstraZeneca, what they use a chimpanzee. In other words, a non-human primate adenovirus, which infects non-human primates, but doesn't infect human beings. Now that's used to carry that RNA into the cells. That adenovirus doesn't multiply. It's just used as a vehicle to get the RNA into the muscle cells. And again, it's the same process. The RNA then codes for the protein stimulates the immune system. The Johnson & Johnson uses another adenovirus. It's a human one, but also one which doesn't cause any illness, adeno-26, and the Russian one uses two, an adeno-5 and adeno-26, but it's the same process. The Chinese virus, the Sinopharm virus, that uses actually one of the classical ways. They grow up the virus and they inactivate it. That's whole virus, and it's obviously the proteins of that virus itself will stimulate the immune system. Now, there are other ways of making viral vaccines. None of them have yet been licensed. These are the three main, or actually the two main techniques in those three vaccines which are used. So that's a very, very brief overview of how these vaccines are prepared and how they work in stimulating the immune system. Thank you, Dr. Manzi. I'll leave it there.
Well, thank you very much, Professor Shub, for that explanation. I see that Dr. Anban Pillay is ready to go with his slides, and thank you, Dr. Pillay. The floor is yours.
Thank you very much. I hope you can see the slides. I'm just going to take you through the overview of the vaccines that we are looking at and some that are coming in that the minister announced. If we go to the next slide, which is the AstraZeneca vaccine, you can see that this vaccine, which is being produced by the Serum Institute, is called the Covishield vaccine. It uses a viral vector technology. Its efficacy is between 62 and 90%, depending on the type of trials that have been reported on. It's a two-dose vaccine. The dosing interval varies. In some of the trials, it's been 4 weeks, but it can go up to 12 weeks. It's administered in the deltoid muscle with a needle and syringe. I think you would have seen that on TV in some of the countries. It's a fully liquid vaccine, so it doesn't have to be diluted. The good news about it is that it can be stored between 2 and 8 degrees. The side effects are fairly mild to moderate. From the reports that we've had thus far, the side effects relate largely to tenderness in the injection site, headache, fatigue, myalgia, pyrexia, and a bit of chills. But these are usually only for a few days. Most vaccines probably have the similar effect in terms of the immune response, and individuals may experience these. But again, just to emphasize that these are very mild symptoms. Coming next to the Pfizer vaccine, this is an mRNA vaccine. Its efficacy is 95%. It is a two-dose vaccine as well. The dosing interval here is 21 days apart. It's administered in exactly the same way as the AstraZeneca vaccine. This vaccine does require some reconstitution, which means that it'll have to be mixed. And once it's mixed, it lasts for about 6 hours. So very important in our program is to make sure that we have sufficient people to be vaccinated once a vial has been diluted to prevent wastage of the vaccine. The challenge with the vaccine is that it's stored at -70 degrees. At the vaccination site, it can be kept to between 2 to 8 degrees for about 120 hours. The side effects fairly similar to the AstraZeneca vaccine in terms of the most common side effects. They happen. particularly as they relate to polyethylene glycol, PEG. But I think it's important to bear in mind that this vaccine is currently the most widely used vaccine since it was the first one out of the blocks. So we're probably hearing a lot about this, but as the other vaccines are being used, we'll have more information about them. This vaccine, the Johnson & Johnson vaccine, is not registered as yet, but we're certainly waiting for the registration. We anticipate the phase 3 studies coming out this week, hopefully, which will tell us a lot about the efficacy and the safety of the vaccine. It's given in exactly the same way. The great advantage of this vaccine is it's a single dose vaccine, so you don't need to come back for your second dose. And it's stored as well between 2 to 8 degrees. The side effects that were reported with this vaccine as well, very mild, similar side effects to the others. Pain at the injection site, a bit of fatigue and headache. As I said, very, very short-lived from all the data that we have. Then the vaccine that comes out of China, the Sinovac vaccine. This vaccine is an inactivated virus. Its efficacy seems to range between 50 to 70%. We don't have large trials to rely on here, and some of the small trials is what we're reporting on. It's not registered here yet, but it is being used in a number of countries. It's a 2-dose vaccine, 14-day interval in between, administered in exactly the same way, and is also stored between 2 to 8 degrees, and the reports about side effects are very similar. Coming to the Sputnik 5 or V vaccine, this vaccine is produced in Russia. This is an adenovirus vector vaccine, efficacy around 92%, a 2-dose vaccine as well, with a 21-day interval in between. It's storage between 2 to 8 degrees. It does require a diluent as well because it's freeze-dried. The side effects are mild and very similar to the other vaccines in terms of the side effects that have been reported with this vaccine. And then finally, the Moderna vaccine. This vaccine is an mRNA vaccine, similar to the Pfizer vaccine, with efficacy close to that as well, 94.5. A 2-dose vaccine with a 28-day interval, administered in exactly the same way in the deltoid muscle. Its storage is not -70, it's -20, which means it can be kept in the freezer. And at the vaccination site, you can keep it between 2 to 8 for 30 days, which is quite helpful. Side effects, similar profile to the other vaccines. And it also has polyethylene glycol, which would probably cause some allergies in people that are allergic to that. So similar side effect profile to the Pfizer vaccine. I will stop at that point, Dr. Manzi. Thank you very much.
Well, thank you very much, Dr. Pele, for that very informative presentation. And now we will invite Ms. Mulani Wilmerans to then take us through the electronic system. This is obviously a very important aspect of the rollout strategy to ensure that everybody can be recorded and that we can keep track of everybody who is receiving their vaccines. May I check that we are ready to share Ms. Wilmerans' presentations?
Good evening, Lwazi. I cannot manage to share. It says host disabled participant screen sharing.
Okay, I'm going to give an opportunity for the admin to release, and Ms. Wilmerans.
I can I can share now. Thank you very much.
Okay, thank you very much.
So, good evening, Minister, Deputy Minister, DG, colleagues, panelists, everybody that's on this webinar. It's my task to just give a very short overview of the EVDS. The EVDS stands for Electronic Vaccine Data System. This is an integrated online system that will allow us to capture all the relevant data that is associated with the administration of the vaccine. It's a data secure platform. It's an a platform that has been built with an enterprise architecture that complies with national and international security standards. We've built in quite a number of controls that will allow us to, the system, to enable processes for effectiveness and efficiency. I'm just going to give you a very short snapshot of the EVDS. So in terms of the electronic vaccine data system, the process for phase 1 starts here at number 1, which will, for healthcare workers to be enrolled for the vaccination. And this is linked to an electronic online application, which I will share more information with you just now. The second step is where the healthcare worker that has enrolled on this platform will be receiving a message to say that you have, you can go at this date to this place to go and receive your vaccine. The healthcare worker vaccinee, in this case for phase 1, will then go to that vaccination site with their ID book and their medical aid details, if they are on a medical aid. They will also receive an SMS from the system to say that they can take to the site. And on that SMS, there will be a vaccination code, which they will show to the vaccinator at the vaccination site. The vaccinator confirm that they are eligible to receive the vaccine and also confirm vaccine consent. After that, the vaccinator will give the jab or administer the vaccine. It captures the required information on the EVDS, records the vaccination code that comes from the SMS. The healthcare worker will receive a message, an SMS message, that they have received the first dose of the vaccine, and they will receive a message to say when they can receive their second dose. And this is the whole process for the EVDS in terms of supporting the vaccine administration. At the end of this, after the second dose, the vaccinee will be able to access through a secure platform an electronic vaccination certificate. And this whole vaccination process that is supported by the EVDS is also linked to the supply chain management, so that we ensure that when a vaccinee arrives at the vaccination center, there is enough supply to be able to vaccinate the vaccinees. The next part that I quickly want to zoom in to, which is very important and that will go live very soon, is the online vaccine self-registration for healthcare workers. This is an online application that can be accessed via a cell phone or via the internet on your computer, and it will just capture basic information to be able to then assign you or to tell you to which vaccination site to go, as well as on which date you can receive your vaccine. So we are saying that it's a vaccination appointment, and if you register on this platform, you will get an appointment and you will be sure that you receive your vaccine at that vaccination site. Everybody, all the healthcare workers that register, they will just submit very general information, and one of the fields that they would complete is just their place of work. We will then use this, and we will then look at the registered vaccination site, and then we'll allocate where the vaccines is available, and we will allocate this individual to go to this vaccination site to receive their vaccine. The information that is provided on this portal, we will also use this to communicate with those that's registered on the portal about the vaccination program, where it's necessary, and the communication will be through this application. All healthcare workers, public, private, clinical, non-clinical, should register online on this platform. This will allow us to communicate with you when and where you can receive your vaccine. How will you know when this portal is alive and that you can register? There will be extensive communication to inform everybody, all healthcare workers, through different platforms and mechanisms. Some of these that we've already started populating is social media, professional organization, healthcare worker, the employers of the healthcare workers, as well as the labor unions. And thank you.
Well, thank you very much, Ms. Wilmerans, for that. And I hope this does give reassurance to track all inoculees. Now, I have been requested to move the segment service delivery model and funding to the end, as Dr. Aquina Tulari is having activities and we'll see in circumstances that surround digital communications. But what we will do then is that I will ask Professor Kollega Mlisana to then start getting ready to present on myths and misinformation. I see that Professor Mlisana has been enabled to be able to share her screen. I will give her an opportunity to do so. There we go. Thank you so much, Professor. Please, over to you. The floor is yours.
Thank you very much, Dr. Manzi, and Honorable Minister and the Deputy Minister and everybody, all the colleagues on the webinar. It gives me great pleasure just to talk a little bit about the myths and the misinformation surrounding vaccines. And I'm smiling because there's a lot of information that's going out there and it can be confusing. But I think we really just need to, make sure that we know we know where to find the correct information, and we will be fine. And I'm trying to move my slides, and I'm not sure why it's not moving. Okay, all right. So I thought where I will start actually is just to define, when we talk about myths and misinformation, what is a myth? It basically, everybody knows that it's a widely held but false belief or idea. And I could not resist not to translate this. NgesiZulu sithi myth inganekwane. Itori sixoxa labantu ingane ezincane mazikhula. And in Xhosa kuthiwa intsomi, which is really just a belief that we all know which is false. Now, what about misinformation? It is when we're talking about false or inaccurate information. And there's even a new word that now is called disinformation, which talks to a false or misleading information that is spread deliberately, and the emphasis being on deliberate. So we really need to be careful about disinformation as South Africans. There's a lot of talks about 5G and viruses, but really let's just be all clear that viruses cannot travel on radio waves or mobile networks. They are not able to do that. And therefore, the 5G mobile networks do not spread COVID-19. In fact, we all know how the viruses spread. And in fact, we have seen the virus spreading in countries that don't even have 5G mobile networks. So really, there is no way that we can get the virus being transmitted just because we've got a 5G. That does not happen. I put this one up because I thought I just want to show people the magnitude of COVID cases. If you look at us as the country, we are sitting in very, right on top there as Africa, as a continent. And you look at the rest of the other countries, the numbers of cases. So really, when we're looking at numbers, people are often associating all these myths with some of the US, citizens. But if you're looking at the US, it has got 30.5 million cases, compared to 3.48 million cases in Africa. And as we all know, know that within our country, we've got 1.42. So you can see that the magnitude of cases is not in Africa, but it actually is in the US and in other countries as depicted by this graph here. And secondly, what about deaths? Is the virus here to destroy, the Africans? If you're looking at deaths, there are more deaths, way more deaths in the US compared to deaths in Africa. And really, when we look at all this, there are far more deaths in the West than in Africa. Then, what about the vaccine itself? I keep saying this, that the advantage that we have as a country is that there are other countries that have already started vaccinating. As we speak, this was yesterday, more than 71 million doses have already been administered. So we are able to look at those and we are able to follow, and look at adverse events. And as Dr. Pillay has already mentioned, really the adverse effects that have been documented have been mild. So we've got the advantage that more than 70 million of people have already had the vaccine. And in fact, this is the vaccine doses. But if you're looking at those that have received the two doses for those vaccines that need 2 doses, 6.56 million already have already been fully vaccinated. And so we can monitor, and there has been nothing untoward that we have seen thus far. So basically, we need to know that vaccination saves lives. And as Dr. Pillay showed, it actually, a vaccine, the vaccine vials contain more than just 1 dose. It's all fluid. And so there is no way there could be a microchip or a tracking device in that vial, because that 1 vial will actually be used for more than, there's some that contain up to 5 doses and even more. So really, all vaccine ingredients, they get declared to the regulatory body. So when the SAPRA, evaluates and looks through the dossiers of any company that wants to bring a vaccine, it's mandatory that the full ingredients that are in the vaccine are declared. So there is no vaccine that has got a microchip or a tracking device. Will these vaccines alter our DNA? The answer is no. There's no vaccine that is going to alter the DNA. As Professor Shub has eloquently described to us how these vaccines work, if we're looking at the messenger RNA vaccines, all that they actually are a set of instructions that then inform the cells of the body to make these proteins, which then the body responds to in stimulating an immune response and prevent or fight the disease. So it is not going to alter the DNA, not in whatever form. And really, I just want, as I'm finishing off, to say, we are a nation that vaccinates. We vaccinate our children. Every mother knows that they must keep their road to health chart and they go and vaccinate and get their children immunized. In fact, if you're looking at our childhood immunization coverage is above 80%, and this was in 2019. And therefore, my message tonight is that we need to know that even if the government can bring the best vaccines, vaccines do not save lives per se, but it is vaccination. So which means we all need to line up to get vaccinated so that we can actually make an impact and make sure that we reduce, and hopefully we get to a stage where we talk about herd immunity. And the last bit I want to say, to us as South Africans, please let's get into the habit of checking whatever information that you come across. Don't accept things at face value. Don't believe everything that you read on WhatsApp messages, but check the facts and make sure that you protect yourself and you vaccinate against COVID-19. Thank you very much, Manzi. Lwazi, sorry.
Thank you very much, Professor Mlisana. Your authority and expertise is really an important voice, and we really, really appreciate that you have come to share your message with us. Every mother knows that you must vaccinate. Now I'm going to invite Dr. Boitumelo Semete-Mukukotlela, the CEO of SAPRA, to talk to us about the Section 21 authorization, as well as safety and pharmacovigilance that is undertaken by the regulator. CEO, are you ready to share your slides, or are you enabled?
I'm going to try again. Thank you very much, Dr. Lwazi. I'm ready to share my slides. I hope you
Thank you very much, CEO. Thank you. The floor is yours.
Thank you. Let me just put it on. Good evening, Minister. Good evening, members of the MAC Advisory and other colleagues, and good evening to the viewers. So as indicated, SAPRA will share an update on the regulatory status of the various vaccines, but I'll do a deep dive on the specific one that has recently been authorized. So in terms of applications that are currently in our pipeline, you've heard of a number that are still in development and some that are authorized by other countries. However, as we sit at the moment, we've got the Janssen vaccine that is currently under what we call a rolling review submission, and this is currently ongoing. We then have the Serum Institute AstraZeneca vaccine, which we recently issued a Section 21 authorization on, and this is a vaccine that has market authorization, conditional market authorization by the European Medicines Agency. It has emergency use listing in the UK, and it also has emergency use listing in India. We also received an application from Pfizer for their vaccine, which currently has emergency use listing in the UK, the US, as well as a WHO emergency use listing, and this is also under review by SAPRA. I'll do a deep dive on the Section 21 process that we followed. Again, it is to give the public confidence, as Prof. Koleka was saying, that SAPRA follows quite a rigorous process in getting to a position where they determine the safety, efficacy, and quality of a medicine. So Section 21 is a mechanism that we utilize, and it's under the Medicines Act, to grant access to unregistered medicines. So this is what when you see with other regulators, they would typically call it emergency use authorization. What we do with this mechanism is that we make a product available for a specific period of time that we determine. Again, it's applied where there are conventional therapies that have been ruled out or that have failed or are unavailable in the South African market. They also, where we apply Section 21, is where there are specific quantities or specific individuals or patients that need to access the product urgently. And this is the case now with the Covid-19 vaccine, wherein you note the specific quantities and a very specific cohort wherein it will be rolled out in this initial phase of our national rollout program. Again, we issue it where there's adequate scientific data that clearly indicates the risk and clinical benefit. In this review process, we always have regard to the health product safety, efficacy, and quality. And as I've indicated, this is a product that a mechanism that we've utilized extensively in the past. Even when it comes to COVID, we've utilized it for remdesivir, we've utilized it for the serology tests that are currently available, etc. So the specific product then that has this Section 21 application, the Department of Health was the applicant. It is manufactured by the Serum Institute of India. As indicated by Dr. Anban Pillay, we're expecting about 1.5 million doses, and that's what we've authorized. And again, this is targeted to the healthcare workers. We went through quite a rigorous and a very thorough process as SAPRA. We put together a working group of experts that are very, very much knowledgeable in the area of vaccines and clinical vaccine virology, etc. And we looked at the following: the quality of the product, where the product is manufactured. We looked at its clinical efficacy. We also looked at its safety and post-access monitoring, which also includes pharmacovigilance reporting requirements. And I'll speak to these briefly. So when it comes to quality, we look at the manufacturing process. That is it an appropriately validated process? In this case, because AstraZeneca had entered into a technology transfer agreement with the Serum Institute, we needed to ensure that the product that comes out of the Serum Institute is comparable to the product that is then manufactured by AstraZeneca. So we had a lot of scientific data around that. We also looked at what we call the release specifications by AstraZeneca for this product of the Serum Institute. Again, when the product arrives in South Africa, we do what we call a lot release, and this is to test and verify the quality of the vaccine that is available in South Africa. So in this case, with this Covishield vaccine, when the product leaves India, it will go through a lot release by the Indian National Control Laboratory. When it arrives in South Africa, it will undergo a further lot release verification, and this will be conducted by our South African National Control Lab. These are labs that are all under the WHO guideline, and they always are collaborating on their protocols and on their processes. So we're quite comfortable with the quality of work that comes from both these labs. When it comes to the facility itself, we had to, again, ensure that we are quite comfortable with the quality of the manufacturing and that the manufacturing process, it complies with good manufacturing practices. So we reviewed the acceptability of the site with respect to good manufacturing practices. Again, this is a site that we have evaluated as SAPRA in the past. They have received a GMP status before, so it's a site that we are quite familiar with as a regulatory authority. We also did, when it comes specifically to this vaccine, we did an additional desktop review of the process that is specifically utilized to manufacture this vaccine, and we were quite confident and comfortable that it still complies with good manufacturing practices. Again, as I've indicated, this is a company that we've dealt with before, the Serum Institute of India. They do have GMP approval from SAPRA for other vaccines that are available in South Africa, being the BCG vaccine as well as the rotavirus vaccine. When it comes to the clinical efficacy of this product, we looked at the preclinical studies as well as the phase 1 and the phase 2 clinical studies. We reviewed these and we found them to be acceptable, and that the safety and the efficacy outcomes were acceptable. We also reviewed the early results of the ongoing phase 3 trial. And again, there's a trial that is ongoing on this product in the country, and we were satisfied with the safety as well as the efficacy data that was provided from these early results from this phase 3 clinical trial. Very important, because I know we'll probably get a question around how quickly these vaccines were developed. Are we certain about their safety? How are we going to ensure continuous monitoring? So we've got a very detailed program that we've put in place. And again, it starts with the manufacturer providing periodic reports on what we call the worldwide database on a 6-monthly basis as these vaccines are made available across the world. Again, the manufacturer will provide us with a summary report of these periodic safety updates on a monthly basis. But furthermore, we will be also getting and working very closely with the Department of Health to get reports on any adverse events following immunization. In our process as SAPRA, we also need to do an annual review of the drug safety information after the depletion of a specific stock. As indicated, the matter of the adverse events following immunization is quite important, and we'll be working with the Department of Health on that. Where there are serious effects, we will receive these reports on a 24-hourly basis. We will then assess that and we will act accordingly. Where there are non-serious, as some that you've seen already being reported, we'll get these reports on a 7-day basis. Furthermore, to ensure that we continuously monitor this product as it's been available to us as in South Africa, we will do what we call pharmacovigilance assessment of its safety. We will do very thorough reporting, monitoring, and we've put in place a reporting tool that will be utilized. And this is called the MedSafety app. This has been developed in partnership with the MHRA. This is the Health Products Regulatory Authority in the UK, and we're working with other African countries, again, around this medicine safety app. We've designed the app so that it's simple to use. It will be available on Apple products, on Android products, but also it will be available on our website as well as the Department of Health's website. In instances where we don't have these digital platforms available, there will be a soft copy, a hard copy document form that is available that will be utilized at the facility to report any side effects. And this is exactly the same form as what you see on our, that will be on our website. Again, there's been a number of awareness programs that have been held with healthcare professionals around the profiles of these vaccines, on how to report these adverse effects following immunization, utilizing this app. Also, some of you may have heard about these breakthrough infections. So that is where if you receive a vaccine, you may also get infected. Again, because we are aligning the MedSafety app with the current testing web-based tool, we will be able to link the two and detect any breakthrough infections. Issues such as causality assessment, so that's where we look at what is the relationship between a specific adverse effect and an individual having been vaccinated. We will do those regularly. And again, I can't stress the importance of having to report, and we'll definitely engage with the media, with the public around this MedSafety app in the next few days. So this app enables us to do a passive surveillance wherein you can spontaneously report utilizing your mobile device, logging onto our website, and provide us with all the details around how you're feeling and if you're experiencing any adverse side effects. We can also utilize it to actively monitor specific recipients of the vaccine. And because of the way that it's structured, we are confident that we'll be able to get good quality data. It allows that we get report from the healthcare practitioners, but also from the public. So we're expecting quite a large volume of data that we will be receiving, and we're putting together a team that will be analyzing this data and continuously advising us on what is happening as these vaccines are being rolled out. Again, we will be able to see trends, and we will be then able to make decisions quite rapidly as we get this data. So just to conclude, the key messages that we would like to share are that as a health products regulator, we would like to give the public confidence that with this specific Section 21 authorization for the Covid-19 vaccine, we've gone through a very rigorous review process with our expert working group that has extensive knowledge in this area. We also have worked, and we continue to work with other regulators across the world that we align with, and also with the WHO. So thank you very much for your time.
Thank you very much to the CEO of SAPRA, and indeed let us take this opportunity to appreciate the regulator for getting us here. It is no mean feat to get us to this point where we are actually able to roll out the vaccines. I am now told that Dr. Tulare is available for the most anticipated segment of these presentations, and that is the service delivery model. Now, while Dr. Tulare is preparing her slides, when she is done, as the Minister of Health alluded to earlier, the service delivery model and the service delivery strategy is a multi-sectoral approach. And we are extremely fortunate this evening to be joined by representatives of the various sectors. Various on two together with the Department of Health in collaboration. Delivery and is very user friendly.
I'm sorry, Dr. Manzi. I think we need to check your sound. It might be getting interrupted, but you can proceed. But I think there have been a few comments that more people can't hear. So please just attend to it. Thank you. Please proceed, Dr. Tulare.
Thank you, Minister, Deputy Minister, co-panelists and honored guests. I'm going to do a presentation on funding, cost recovery and service delivery platform for phase 1 of the vaccination rollout. The purpose of the exercise of vaccinating is to achieve herd immunity against the COVID-19 virus. And based on the advice that we have received from the Ministerial Advisory Committee on Vaccination, 65% of the adult population needs to be vaccinated to ensure that the population has got the immunity that it needs. And if we look at the South African population, 65% translates to 40 million people in the population. And I'm going to break it down further, that if we think we have got 40 million people that requires vaccination, 7.1 million of this are insured in the private sector by medical schemes, whilst around 32.9 are what we call uninsured. If you look at the population of healthcare workers, which is going to be the purpose of this phase 1 inoculation exercise, we have got about 1.2 million public servants who are insured or who are working in the public sector, and both in health and other sectors, and about 350,000 are insured in the public sector, and 170,000 belong to GEMS. The vaccine itself has been designated as a public good, and it will be delivered free at the point of care, and its delivery is based on the principles of social solidarity, so that we look after each other, all of us in our society. The funding for the vaccine will be predominantly from the fiscus, but it will be augmented by private funding sources. And as indicated earlier on, there are various sources from which we are going to procure the vaccine, and I'm not going to elaborate on these further. Also to indicate and to re-emphasize that government will be the sole purchaser of the vaccine for the national vaccination program, and to secure access to vaccine, government will ensure that we do this at the lowest possible price that we can negotiate. An identified entity will receive the vaccine and act as a central distributor for the vaccination, for the vaccines on behalf of government, and this entity will recover costs on behalf of government. As Milani had presented earlier on, we are going to be using an electronic vaccine data system that will coordinate, ensure that facilities that are accredited are on the system, that we coordinate a supply of vaccines, the pre-booking system and the vaccination itself, recording who is vaccinated, who is not vaccinated, and also helping us with any other information that is going to be used for planning, execution, and monitoring of the vaccination. In terms of cost recovery, we have got 3 approaches to a cost recovery mechanism, and this entails looking at the insured patients, how we recover costs from insured patients, how funding will be meted out for uninsured patients, and also the participation of private sector, such as private hospitals, industries, corporates that want to assist in augmenting the funding of the vaccination program. Then I'm going to break down this presentation into what will happen to those persons who are insured. For persons who are insured, funding will be derived from medical schemes. And for these individuals or persons, the vaccine will be administered free at the point of vaccination, at the point of service. In the private sector, private providers, including pharmacies who want to provide services to the insured persons, they will procure the vaccine from the central distributor through their wholesalers using a mechanism that we call a single exit price. A single exit price is a mechanism that is defined in law through the Medicines and Related Substance Act, Section 22G. So it allows the country and government to publish a single exit price from which we can buy the services that we want to buy. Providers in the private sector will bill medical schemes for the cost of the vaccines as well as the administration fee, and will be paid through what we call a prescribed minimum benefit. The prescribed minimum benefit is described and contained in the in the Medical Schemes Act, and it's a mechanism, one of the mechanisms for paying for benefits. We have already declared the vaccination for COVID-19 as a prescribed minimum benefit, which means that schemes are obliged to pay for this service. Schemes will be expected to pay directly to those that are providing services, whether it's hospitals, community pharmacies, general practitioners, or whatever mechanism that we are going to be using to provide the service. And they are going to pay this through what we call alternative reimbursement mechanisms, either prospectively or retrospectively, but it's going to be an inclusive fee, and we call this a capitation fee. And in case of insured healthcare workers who want to be vaccinated in our public health facilities, the vaccine will be supplied to our public health facilities, but our public health facilities will be regarded as designated service providers that can be paid by medical schemes. And they will be able to claim from medical schemes, and the money will come back into government through a system where the funds are retained and go back into the fiscus via National Treasury. As indicated, even for insured persons, they have to go through pre-registration, they have to go through making a booking and coming into a facility that has been assigned to them in line with what Ms. Volmarans explained earlier on. So the electronic vaccine data system will be applicable in this instance. For those persons that are uninsured, and I had indicated that our population, we've got 32.9 persons who are eligible for vaccination, who are uninsured, and of this, even the healthcare workers, there is a proportion of these that are not insured. For this component of the population, the public sector is the preferred provider for the vaccination. And since vaccination is a public good, government will provide funding for this section of the population. Uninsured health workers will also be funded by government, and in other instances where, for example, they're in the private sector and there's a private employer who is willing to pay for their employee, they will be allowed to do so, and there is a mechanism that I will describe in the next slide of how they are going to do that. For the uninsured who are using our public facilities, the vaccine will be received from the central distributor, but our provincial departments and our districts will not be required to pay for the vaccine from the central distributors. In the private sector, if our uninsured population wishes to access service through private providers, the private providers will have to purchase the vaccine through the single exit price mechanism that I explained earlier on, and they will be purchasing this through their wholesalers from the central distributor. But also of importance is that no person, uninsured person or insured person, will be expected to pay when they access the vaccine. So vaccination will be free at the point of service. Where there is a need to augment the public sector capacity to provide services to uninsured persons, government may or will contract private providers based on need, their location, capacity, and other relevant considerations. This is not something new. Government has already embarked on contracting private providers, for example, with the distribution of medicines with the central chronic medicine dispensing and distribution system, the CCMDD, where we distribute medicines to remote areas through contracted providers such as pharmacies. So these contracted providers, as indicated, may include private pharmacies, general practitioners, and other providers in line with their scope of practice. Uninsured persons who may wish to access vaccination services through public facilities or accredited private providers will also have to undergo a system of pre-booking and also making an appointment, and also for them to have their vaccination recorded and collected into our EVDS. The contract that a government will be getting into with private providers will include a portion for administration fee that we have set between 50 and 60 Rand per patient, and this will be inclusive of VAT, and government will reimburse this to private providers. Of importance also is that our uninsured persons will need to have their identity document, and we have, as they are registering, if ever they are not on the health patient registration system that is already in existence in our facilities, then this will be activated so that we are sure that we're identifying the correct person. Then I had indicated that, a private sector or corporates may wish to also provide funding and services for their employees. It is important that we recognize the participation of the private sector, because if we want to achieve herd immunity, we need to have a collaborative effort amongst all of us, amongst all key stakeholders. And business funding should be aimed at ensuring that we cross-subsidize the cost of herd immunity and the associated social and economic benefits of achieving this herd immunity. And a business may also opt to make a contribution through an identified mechanism to ensure that this herd immunity is achieved. Business has indicated that they would want to opt either to cover a population of the unemployed, the population that is uninsured, or the population that is residing in the vicinity of the places of work. And this they may do through their occupational healthcare services that are available at workplaces or through contracting for such services. If ever services are procured for delivery of the vaccination through the private sector and corporate mechanism, they will have to procure the vaccine through the central distributor using a wholesaler, also at a single exit price. What we also want to be clear about is that if communities or employees are vaccinated, they are going to receive their vaccine free at the point of service, and the business or corporate will bear the cost. Persons wishing to access vaccination may do so through their workplaces, or if ever the employer identifies an accredited provider, whether it's a GP, it's a nurse practitioner, or it's a pharmacy, they may do so, but they are also going to be required to register through our electronic vaccine data system and with pre-booking and recording of all the vaccination activity. In summary, therefore, let me say that if we have the public sector as a delivery platform, I'm going to break down what will be the role of medical aid schemes, the service providers, where the stock will be coming from, and the type of reimbursement. So for the public sector health facility, personnel who are on medical aid will have to be funded through their medical schemes. The services that are provided in the public sector hospitals or facility will be delivered through a vaccination team. And I just want to remind ourselves, we had said that the public sector must be a designated service provider for a scheme such as GEMS or any other scheme that is not GEMS. There are lots of other schemes that are covering public health sector employees, and these may also be a part of the process of paying the service provider, which will be the public health sector facility. The stock here will be public, but reimbursement will derive from the schemes, and it will be retained by Treasury through the DSP arrangements. For those personnel that are without a medical aid coverage, but they want to be receiving the service in the public sector, the services will still be delivered by a vaccination team. The stock will be none, but there won't be any need for reimbursement since these are persons or the category that will be funded directly through the fiscus. If the service is delivered in the private sector and the person is on medical aid, and the services will be provided by the private health facility, the stock will be private. It will be procured through the single exit price from the central distributor via the wholesaler, and the provider will submit its claim to the medical scheme, and the medical scheme will reimburse the provider. The fiscus will retain the funding through the initial mechanism of purchasing from the central distributor. For personnel without medical aid, there are two options. Option one, where the services are provided by an employer through the occupational health service facilities at the workplace. The stock in this instance will be private, and the employer or the one who is going to be providing the service, either the corporates or other private role players, they will purchase their stock of vaccines from the central distributor at a single exit price, and the employer will supply the vaccine to the workplace or to an identified service provider. And the employer or the corporate will have to reimburse those that are providing services at the occupational health facilities. The other option is to refer those that are without medical aid back into the public sector, which is the preferred option for delivery. My last slide. If ever we are looking at a variety of platforms that we can use also to deliver, we have identified a critical component as private pharmacies that have got a guaranteed cold chain in their facilities. And they may opt to look at after medical aid patients or those that are without medical aid. In this context, the service provider will be the pharmacy, the stock will be private, and the pharmacies may either purchase as a group through their group purchasing mechanism, but they will also be purchasing from the central distributor at a single exit price, and medical schemes will reimburse directly to these pharmacy or pharmacy groups. If ever the person comes into a pharmacy but they do not have a medical aid, the pharmacy will have a stock that is derived from the public pool, and they will be reimbursed by the state vaccine cost with or without an administration fee. This will depend on the negotiations, and this will be similar to the central chronic medicine dispensing and distribution system that I described earlier on. Therefore, let me thank the Minister, the Deputy Minister, colleagues, and everyone for listening. I thank you.
Well, thank you, Dr. Tulari, very much for articulating the service delivery model. And now, as we alluded to earlier, may I invite our partners to come through. I'm going to introduce each and every one of them. We will ask Dr. Zodwa Ngobese to first come through. Dr. Ngobese is an occupational medicine specialist running occupational health services for various parastatals and private entities throughout the country and in the private sector. She is also a health risk management specialist in the private sector. Dr. Ngobese, please unmute and let us see you, and please do come through with your contributions.
Thank you. I want to thank the Honorable Minister, the Deputy Minister, colleagues, fellow panel members, and fellow South Africans for this opportunity to support phase 1 of the vaccine rollout, all protocols observed. Occupational medicine services, we play a vital role in public health as a whole, in that we are the healthcare professionals working with employers in corporates, private sector, and public entities to manage work-related health issues and exposures. And we also provide primary healthcare services at the workplace. For that reason, COVID-19 has become one of the risks that we manage on a daily basis. It has become our so-called new normal to deal with the management of the risk of COVID-19 on productivity, quality of life, morale of employees, and the workforce as a whole. For private employers who opt to fund the rollout, and also for corporates, occupational health practitioners are well placed to be their foot soldiers. So we look forward to the delivery of COVID-19 rollout program. We view it as a game changer towards prevention of COVID-19 infections, not only locally, but also globally. And we wish to place on record that we wish to be the active promoters of this program in the workplace, because we believe that the health promotion we give to employees can also be shared and add value to their families. So we recognize that our country needs all hands on deck, and we fully support the program in its efforts to ensure and promote high levels of uptake of the vaccine in the country. We are a resource that has the capacity to do that. As some people say, we can, you can, we all can. Therefore, we wish to support government and enable our country to achieve herd immunity as quickly as possible, because we view the vaccine as the one critical public health measure toward stemming the spread of COVID-19 countrywide and globally. For that reason, we wish all South Africans to utilize existing health resources, including occupational health practitioners, as a source of information that will enable them to make decisions on whether to participate in the program or not. I thank you for these few minutes of your time. Thank you.
Thank you very, very much, Dr. Ngobese. Let's move right along to Dr. Tutula Balfour. Now, Dr. Balfour is a public health medicine specialist and the head of health for the Minerals Council of South Africa. Very important figure in the landscape of healthcare in this country. Dr. Balfour, the floor is yours.
Very much, Chairperson. Honorable Minister, the Deputy Minister, all protocol observed. Thank you very much for this opportunity. There is no doubt that business, which is BUSA and B4SA, and the mining sector in particular, can play a major role in the end-to-end planning and rollout of the vaccine program to assist government and the nation. We see this as a very critical national effort. Business has stepped up, as it has done in the past, to offer its support to government in the distribution of vaccines to, in our case, mining employees and mining communities, in line with the clinically established national priorities. As Professor Mlisana had said, the key here is that it's not vaccines that are going to save us, it's vaccination. And therefore, our collective priority and responsibility as a nation is to get as many jabs in arms as possible, as quickly as possible, to save lives and livelihoods. Using our significant healthcare infrastructure and capacity, business, including the mining sector, could have.
I'm sorry, Dr. Balfour. Dr. Balfour, please just pause there. Dr. Ngobese, please.
Let me just mute.
Dr. Manzi, you are muted, and I think Dr. Balfour is also muted.
Oh, okay, Dr. Balfour, apologies. We just needed to mute Dr. Ngobese. Please do come back and continue your contributions. Thank you very much.
Can you hear me?
Yes, thank you very much, Dr. Balfour. Please continue your contributions. Thank you, we can hear you and we can see you.
Okay, sorry about that. I was saying that, you know, as business, which includes the mining sector, we've got significant healthcare infrastructure and capacity, which can be used to drive the vaccination process. And we hope to be designated as key points of care. It is time for agency and also partnership, and will play an important role with government and with trade unions. If we have the vaccine, we've actually worked that out that the industry can administer about 60,000 to 80,000 vaccines a day. So within 2 months, we could vaccinate between 2.5 million to 3 million people. We currently have a workforce of 450,000 people. So it would mean that would be vaccinating at least 5 more people, you know, per employee that we have. As business, we will look at how we will best support the funding of the vaccine program. I was listening to Dr. Tulare and the various permutations regarding support that can be provided. We are ready to step in, you know, where required to support the funding of the vaccine program. Lastly, a huge area we believe that we can make a difference on will be placing a focus on communication and education and reassurance of employees and communities, and ensuring that as many people as are able will take up the opportunity to be vaccinated. As we heard before, the critical issue here is to get herd immunity in South Africa, and we want to be part of achieving that goal. Thank you very much, Chair.
Thank you so much, Dr. Balfour. And it really is very reassuring that the sector has got so much capacity, not only to communicate, but to also put trust in arms. Thank you so much. Some of our viewers, television viewers, he's a media personality and advocate on TV and radio, social commentator, and host and owner of Dr. Fundi Digital Health Channel. Dr. Nyati, the floor is yours.
Good evening, Chairperson, Honorable Minister, Dr. Zwelini Mkhize, Deputy Minister, Dr. Joe Patla, eminent experts and co-panelists and many distinguished participants within this webinar. I've been asked to come and talk more as a primary care physician, you know, which is, other people can see those as family doctors, but I play a role at different levels. One, yes, at primary care level, in communities, but also, you know, I have a company that plays a role in health risk management or employee health and wellness programs, that is in workplaces, and then also the role as somebody who's got a digital channel and, you know, gives opinion on media. Now, I think listening to Dr. Tulare, it's very important that primary care doctors, that is GPs, individually and also as groups should be roped in to play a positive role. Because if you look at the number of doctors that this country has, the majority of doctors are actually primary care, doctors. They are the nearest people to the communities. They have established relationships and trust by those communities. And if they are able to speak the local languages, they can play an important role in terms of public health education around the vaccines, answer questions, the myths, misinformation, disinformation. And so I'm saying for this program to succeed, and make sure that by the end of the year, the 2/3 or 7% is achieved, we need to have the primary care physicians playing an active role. They can make their practices available, as vaccination sites. And if they meet standards in terms of cold chain, they can be able to play a role to actually vaccinate, people. And so I'm saying, that engagement with organized primary care physicians needs to happen. Obviously, a lot of training that needs to take place so that they can play the roles that I've just mentioned. And then some of us, we also play a role in media where we influence a lot, in terms of dealing with misinformation, disinformation, and, demystifying the myths. So in all of those roles that we play, workplaces, in the media, and in our practices, I think it's going to be very important for the department to partner, with this sector. Thank you very much.
Thank you very, very much, Dr. Funde. And indeed, we do agree that the role of the family physicians, particularly the community family physicians, is particularly critical, not only in ensuring that we do achieve that herd immunity we keep talking about, but also in their ability to be able to communicate with